Good evening. Today we are going to do a live in-box case, right coronary artery chronic total occlusion. With me, my team, Dr. Damodar, cardiologist, and our nursing team and cath lab team are ready to go into the case of today. So before that, Dr. Damodar will introduce the case in a couple of minutes, and then we'll discuss the live case. Yeah.
Good evening, everybody. Coming to the clinical history of the case, it's a 55-year-old gentleman, known case of systemic hypertension, with the history of effort angina since last 10 months. And it was evaluated outside, and angio was showing RCA CTO, for which it was attempted in February 2020. After that, patient was put on optimal medical management. In spite of that, patient continued to have class 3 angina, for which he was referred for further management. And ECG was unremarkable and echo was with normal LV function. Coming to this coronary angiogram, it's a left system showing LMC block with middle AD almost 50% block length, and you can see the distal RCA frilling retrogradely from the left system. And you can see good interventional collaterals. And this is RCA injection. You can see the proximal RCA almost significant 90% stenosis. It is followed by CTO segment of about almost to more than 20 mm length with bridging collaterals. And coming to the IGCTO score, since the entry looks ambiguous, it gets a score of 1 with no calcium and no bending, and occlusion length is more than 20 mm, so it scores 1. And since it's a retriation, the total score comes to be 3. So, and this is anatomicogram representing the RCA CTO and left system with good septal intervention collaterals reaching the PDA and PLV branch.
Okay, so this is a case of right coronary artery total occlusion, which was already attempted outside and failed to complete the procedure. So I reviewed the old PCI. So the wire went subintimally up to the crux, and where they stopped. They didn't progress with balloon, and they couldn't do parallel wiring or whatever next method. So they closed the case there. So with that backdrop, we are taking this case of right coronary artery CTO. So we started with dual injection. So you can see it's a long CTO. And the most important thing is the distal vessel. So distal vessel visibility is not great. It is visible, but it is not great. So not great because for my antegrade wiring, I need a good distal vessel. So if I have to try a parallel wire or other techniques, I need a good distal vessel. See, another problem is block is extending up to crux. So see, that's another problem for antegrade technique. So if I go through subintimal and end up in PLVB, then I may end up in closing PDA. So that remarkable point here is distal vessel clarity is not that great. So in dual injection, and coming to the proximal cap. So proximal cap is it's ambiguous, non-ambiguous. It is debatable. So I would say it's non-ambiguous, but there is a bridging collateral, so which is quite tortuous, and I really don't know whether I can track that bridging collateral, but my first attempt will be always try and track the bridging collateral if it happens. So okay, length is long. So in this case of non-ambiguous cap with a good interventional collateral but poor distal vessel and CTO extending up to distal cap. So my first choice is I'll go ahead with the antegrade wiring. So I'll put a microcatheter in front of proximal cap, take an injection and see how it goes. How your microchannel is visible, and based on that I'll try an antegrade wire escalation, and if it progresses, fine. If it doesn't progress, I'm going to switch to retrograde because I have a good collateral with a retrograde route. So that is my plan of strategy. So reason why I want to jump early to retrograde is because of the bifurcation. See, the CTO is clearly extending up to crux. So I don't want to lose any branch. So in this patient, so that's why I prefer to go to retrograde rather than trying on parallel wire and ADR. Okay, I place a microcatheter in RCA, mid RCA, and I inject it. So you can see here now. So when I injected there, so there is a good bridging collateral, but which is proximal to the proximal cap. So it's not coming at the proximal cap. So proximal cap is actually the tapering cap is distal to the collateral. So typically, this bridging collateral we cannot cross because it is looking, outside the proximal cap. So, but there is a tapering proximal cap. So, yeah, with microcatheter injection. So this is how we can actually see, or make proximal cap clear by putting a microcatheter proximal to the cap. I started with a microchannel wire, that is Fuller XTR. See, it stopped progressing from that point. You can see it is just buckling there. So then I decided to escalate wire to Gaia 2. So this is Gaia 2. We escalated to Gaia 2. If you can see clearly, Gaia 2 wire is completely subintimal course. So, but the wire movement is, wire is moving along with the artery. That says we are within the vessel architecture, but definitely we are not in the microchannel which we are able to, make out in angiogram. So, but from there it was not progressing. So now I have two options, either switching to parallel wire or, switching to retrograde. So as patient CTO is extending up to crux and PLOC is extending up to crux, so I decided to switch to retrograde as I don't want to lose any branch at crux rather than, trying on to parallel wire. So yeah, I mean, I've chosen first septal, so it's almost like a CC1 collateral. So I'm not able to clearly see the connection into PDA, but PDA is clearly filling from injection into first septal. Yeah, this is our overview, which is clearly showing connection in the distal branch, distalmost branch. So that is what I wanted to try first. Initially, my wire went into middle branch. It appeared almost I reached, the branch of PDA, but from there you can see, there is a PVC coming up in fluoro, which we can observe, and wire is also buckling, not progressing. So then I pulled wire back. We didn't make any progress. So we just injected into the septal, then we understood. So created a small damage to the septal artery with maybe mild aneurysm. So anyway, usually these things will won't harm the patient. So I next went into distal vessel, distal branch of the same septal. So we could eventually cross with the cyan wire, and then the cyan wire went into distal RCA. This is a crucial thing here. So as the PLOC is extending up to crux, so in such patients, your microcatheter is very important. And if you look at collateral entry to distal cap distance, it is too small. So that is practically here, crux to the cap distance, which is too small. So only the proximal flexible portion of the wire is sitting in the distal RCA. So turning a microcatheter into the distal RCA is definitely going to be a little tough. But in this case, as the collateral, septal collateral is small, I thought of taking only Corsair. So Corsair is easy to cross septal collateral, but I may struck at crux, while entering into distal RCA. So that is one thing which I thought of before entering case. We crossed the septal, the slight maneuvering and, making retrograde wire, adding tension to retrograde wire. So I could negotiate Corsair into the distal RCA despite, the only very flexible portion of wire is sitting in distal RCA. So now Corsair is into the distal RCA. So crossing the crux. So from here, I started escalating wire. So we took Gaia 2 wire. So, and this is a Gaia 2 wire, which made a good progress. So next question comes, see, almost there is more than 10 millimeters of overlap in antegrade and, retrograde wires now. Now we have to decide where we have to do reverse cut. So I'm pulling retrograde wire into antegrade space. So in this case, see, our CTO is starting at the bend. So, and it's not ideal to do reverse cut in the bend because it is very difficult to connect spaces when you are at the bend. Usually, two wires will stay on the opposite sides of the bend. So that's why we decided to go distal to the bend. So, and do a reverse cut. So we advanced antegrade wire a little bit down and then took I think 1.5 millimeter balloon. As it was not crossing, I downgraded size to 1 mm balloon. So, and even that balloon was stuck at the loop. So that's a bend. So yeah, I dilated with 1 mm balloon. So as I couldn't cross into the distal RCA with 1 mm balloon, then I switched my reverse cut site to mid RCA. Yeah, so I switched my reverse cut site to into the mid RCA, that is proximal to the bend. So now you can see my retrograde wire is actually progressed beyond the bend. And it is almost like an extended reverse cut. So I'm doing reverse cut in a normal so mildly diseased segment of RCA proximal to the CTO. So I advanced a little bit further the retrograde Gaia 2 wire and then took I think it's 2.5 millimeter. Yeah, 2 millimeter. So I took a 2 millimeter balloon. So and made sure in two views my retrograde wire is pointing towards the balloon. So that we made sure. Basically, we could enter into the antegrade space, and then retrograde wire entered into antegrade guide catheter also. So at this stage, so whether to externalize or not. So as this patient had osteal disease, which I'll show in subsequently in IVUS also, and which is also visible in fluoro. As this patient has osteal disease, I thought of avoiding externalization because most of the injury which we create to left system happens, when you externalize. When you externalize wire and when you are trying to remove your externalized wire, that is when your guide jumps in and, pops in and creates problems. So that's why I wanted to avoid externalization in this patient. So to avoid externalization, so we tried tip in here. So, but I was not successful in doing tip in the guide next. So that's why, and I had to externalize. So you can see here now Corsair has crossed CTO. Now it is into the antegrade guide. Took a 1 mm balloon and dilated entire CTO. So, and then did an IVUS over the retrograde wire into the PDA. So then we realized IVUS has not entered PDA, but what I realized with IVUS is PDA ostium was small and it is mildly diseased. So then and PLVB was actually a big vessel. So yeah, as PLVB was big vessel, so I took a WMN catheter and crossed into the PLVB. So yes, and then we dilated into PLVB with a 2 mm balloon. So entire CTO also we dilated with 2 mm balloon. And then we did a IVUS from PLVB to decide on stunting strategy. So now we can show IVUS. So this is a PLVB which shows 2.6 to 3 or the lumen diameters, and average is almost like around 2.8 or 2.9. So yeah, in this case, we can take 2.75 or 3. So if you take 2.75, you can put it at full pressure, and 3, you try to put it at a little low pressure. So we decided to took a 3 millimeter, right?
Yeah, 3 millimeters.
So, and the length of lesion, so covering proximal lesion was almost 75 mm. So you can put a bookmark here and just see the length. So it came around 75 millimeters. So we decided to take, 2 stunts here. So one distal stunt followed by proximal stunt, mostly the distal stunt. So we took 348 millimeter stunt. So which we deployed into PLVB. Yeah, see here. So then whether to remove retrograde wire. So before placing stent into PLVB or after placing stent into PLVB. I would always love to keep retrograde wire till stent went into PLVB because that gives an immense support. So once retrograde wire is into the PLVB, once stent is into PLVB, I have withdrawn retrograde wire into PDA, and we also placed another wire into PDA to protect it, and we deployed the stent. So we deployed stent. So we took another stent, proximal, I think it's 3.538. We deployed 3.538 as the proximal vessel is quite big. Average size is around 3.6. We took 3.538. So then we post-dilated. I did an IUS as there was some under expansion distally. So we further expanded stent with the 2.75 millimeter and also then with 3 millimeter downstream. And we dilated proximal stent with 3.5 and then this is the result. So you can see this is result. So once we made sure our RCA result is good, then we have withdrawn our retrograde Y, and I'm just checking collateral, subtle collateral. So there is it's pretty okay. There is a mild probably some laceration at the distal septal, but it's okay. Usually nothing will happen. And we just checked RCA in LIO view. So this is fantastic. So RCA is appearing quite good with all vessels intact distally. So and then we did an IVS from LAD. So to make sure how LAD lesion is. So IVS from LAD, please. Yeah, see, this is the MLA of IVS from LAD. It's a 4.4 mm squared. So MLA is more than 4. So we thought there is no need to do anything to LAD. And you can show the ostial LMCA. And we also studied ostial LMCA. You can see here there is so there is a plaque in ostial LMCA, but there is no disturbance to plaque. So that is very, very important, which you have to make sure before coming out. So there are no dissections as such. We confirmed there is no issue with LMCA and LAD, and we took a final injection of RCA, so which is pretty good.